Good afternoon, everybody. It's a great pleasure to be here, and hello to those who are looking at us on the web as well. The Life Course in Intergenerational Health Research Group is really a collection of epidemiologists, biostatisticians with some input from medical anthropology. Amongst our research interests that are sort of outlined here is a central theme of how does inequality get inside the skin, get under the skin. So we're interested in how modifiable social factors alter developmental biology in such a way that it predisposes the next generation to increase chronic disease risk, and then how that interacts again with the postnatal environment to perpetuate that across generations. In terms of a proposition for today's talk, I propose that one of the things we can do here is we can actually look at how the environment alters growth, interacts with the postnatal environment, both nutritionally and structurally, which alters the maternal phenotype, which in turn feeds into the next generation. So the topic for today that I'd be trying to address is how social and economic transitions over the last 100 years have shifted us from a time of famine to a time of plenty. And also I'll try to illustrate this with some local studies, primarily from Adelaide. But here, for example, is a very interesting example of how rehabilitation, in Stewart's model here, these rats were malnourished for 12 generations, and then a very sudden rehabilitation. In this case, this guy here was rehabilitated in utero, and there's a 20% over-rebound above the background rate of the control animals. So it's a nice example of showing that a chronic multiple generation deprivation can actually give rise to extremely sharp rebound effects. Similarly, the postnatal environment here is extremely important. These littermates suffered deprivation of either protein or total energy in the first year of life and ended up with massively different sizes. But an overwhelming sort of theoretical structure that we need for interpreting some of these the interactions of phenotype and health outcomes can come to us actually through a nice overview of life history theory, which basically tries to raises the question, well, in the race to the grave, what adaptive strategies can we make to actually maximise the number of children or grandchildren that we have? And effectively, it's a debate of go fast and die young, or try and grow slow and make a big investment, either in pregnancy or in conception, pregnancy, and the offspring. And we can find really nice animal examples of this where, for example, the mouse model is an excellent example of an animal that breeds very early, gives birth to very immature young with its high perinatal death rates, and then starts reproducing very fast again. By contrast, we're at the other extreme, where we make tremendous investment in a long gestation, small family size, small numbers of litters. Singletons are normal and better for us. But we also have quite long life expectancies. Now, a nice example of this is David Barker's early work. It's kind of encapsulated in the developmental origins of early disease, which I don't need to go into here for most of the audience, but I'll let you read that for a moment. And really that was based on the very early fetal programming work of David Barker in Southampton, where he did some early observational epidemiological studies, which really look so close to the life history theory work as to be rather spooky. So he looked at hotspots for cardiovascular disease and death rates in the UK, and then found there was actually really quite a nice linear association between perinatal death rates in the 1920s and then deaths from cardiovascular disease 60 years later. Now, this is exactly as predicted from life history theory, and it's really a very nice example. He then went on to find that, in fact, it wasn't just a chance association, but in fact it was a meaningful association. And this has been replicated in many other cohort studies around the planet and has been manipulated in experimental models. And indeed, David's work was rather prescient in terms of linking this to social inequalities, where he said the seeds of inequality in health in the next century are being sown today in inner cities and other communities where adverse influences impair the growth, nutrition and health of the mothers and their infants. Now, there's a range of programming questions that emerge from this that we try and unpack. And we'll step through a couple of nice examples of this today, primarily around how nutrition transition has given rise to increased rates of obesity. And we're interested in predictors of obesity in childhood. I should illustrate also that as communities go through transition, there's an interaction with existing phenotypes. And here is a nice example from Finland, showing that for obese mothers there's an extraordinary steep relationship with standardised mortality rates for CHD, according to the Babel's Ponderal Index. And indeed, for lean mothers, there's a very dramatic reduced risk in this population, in this population at this historical moment, I should flag. Now, and this has really taken us on to contemplating that there's actually rates of change that can be either too fast or too slow in order to minimise the risks of metabolic disease and chronic disease generally. So I'd refer you to that paper. It's a great story. And now this has been tried to be included into a dynamic model of how, amongst members of the International Obesity Task Force, of how over time you can get intergenerational effects here. So this is a classical pathway here for the fetal programming story of the adult maternal nutrition impacting on fetal growth and then chronic disease risk or diabetes in the offspring. But indeed you can actually see there are multiple points for interaction here in modifying the postnatal growth trajectory where stunting can occur, and then also illustrating the importance of the social support structures. Now, we can actually identify even particular populations that are extremely vulnerable. This on the right is a photograph of Ranjan Rajnik, diabetologist in Pune in India, and his Caucasian colleague. Now, they actually have exactly the same BMI of 22.3, but the percent body fat is drastically altered, drastically different, from 9.1% on the left to 21% on the right. Now, Ranjan subsequently went on in his Pune birth cohort to discover what he calls the thin fat phenotype, where the mothers were on average 42 kilos in the first trimester of pregnancy. The average birth weight of the babies was 2.5 kilos, but what he discovered was they weren't missing fat, they're actually missing muscle. So muscle is expensive to build and expensive to maintain. So this thrifty phenotype is manifest in the Pune cohort, and Ranjan thinks with the rising levels of obesity in India and the middle class, particularly at the moment, that there's an unstoppable torrent of type 2 diabetes for the future. Now, I should also mention that growth trajectories and the hitting of developmental milestones are also highly modified by nutrition transition. And on the right, down the bottom here, we can actually see how there's been a decline over 100 years in the age of menarche in girls. Now, this is actually slightly worrying from one perspective, because early menarche also slows down final attained height, which is itself a predictor of mortality from chronic disease. And our group, this paper led by Lynn Giles, was actually using a cohort study here in Adelaide, was able to show that early menarche was actually also related to the chance of death in women who survived to age 65. So we have some evidence to suggest that this cohort, this tendency here is a likely concern for the future. I'll just quickly flag a couple of results from a local study, because we're here in Adelaide. The Generation 1 study led by Vivian Moore. Here it's basically a relatively small but well-characterised cohort study that's fairly representative of children who were born, Caucasian children born at that time. There were serial follow-ups of the children over time, and I'll just flag a couple of outcomes that are of interest for today's talk. Firstly, with regard to maternal body composition, Wana Mufti, for a PhD, was able to show that pre-pregnancy body size and gestational diabetes were positively associated with the child's insulin resistance at age 10, independent of the child's size and weight gain and the mother's weight gain in pregnancy. Now, that's clearly an important outcome given the increased weight of mothers entering pregnancy in the current era. Secondly, we're able to show that looked at the growth trajectory of the offspring, and that work was led by Lynn Giles here. And we were able to identify 4 discrete growth trajectories, including one which was an accelerating and a high growth trajectory. And all of these trajectories could be associated with the size of the baby at the child at age 9. But of the antenatal factors, the most important distinguishing factor was maternal obesity in early pregnancy, and by implication around the time of conception. which was associated with a near quadrupling of the risk of membership of the accelerating group. Then further, we're also able to show that it wasn't merely maternal body composition prior to conception or in early pregnancy that were drivers of obesity, but there's also a social context in which families exist. We're able to demonstrate here that most frequent house moves, the more frequent house moves in the first 3.5 years of life were also associated with pace of growth and body composition. And then finally, it's also, of course, parenting practices and the capacity for parents to, the capacity for parents to actually nurture their young is an important predictor of obesity. And here we're able to indicate that paternal non-standard work schedules plus long work hours by mothers were both independently associated with the risk of obesity in children. And then finally, in terms of when do women start having their families, Emily Steele, doing a PhD with us, was able to demonstrate that economic insecurity, job insecurity, was also a driver of the decision as to when to start having children. And this is really quite severely represented. If women had 5 years of precarious employment, she was about 30% more likely to be childless by the age of 30. And this is particularly evident amongst well-educated couples. So it's an entirely, deferred childbearing is an entirely rational decision under these circumstances. But importantly, these are areas in which there is labour force policy that governs these decisions, and it's clearly modifiable. And then finally, there's been an interesting transition in how we actually think about obesity. When the poor were skinny, we didn't necessarily blame them for being skinny, but now poverty is associated with obesity. We're starting to actually blame the fat for their circumstance and say that it's all a lack of willpower. And this is going to be illustrated in this slide, where it only makes sense as a joke because this woman thinks this man's got it all under control. Okay, it doesn't make sense otherwise. So it's a nice way in which you can kind of think backwards and think about, well, how do we actually think about the social structures that control obesity? Oh, sorry, that's already been done. So finally, in conclusion, what can we do? Well, one of the things we can do is simply follow the WHO guidelines about how to protect women and children. But in rich countries, there are possibly a couple of other things to do with actually ensuring that there is a stable labour force and start factoring in the health consequences, not just for the adults, but actually the potential health consequences for the children when constructing labour force policy and basically constructing any policy whatsoever. So with that, I'll just like to acknowledge the people who helped with particularly the Generation 1 study. And then finally, just to illustrate that we can make nonsense of anything. There's a very nice epidemiological study, observational epi, demonstrating that the density of storks in Germany correlates with the birth rate. But interestingly, it was actually replicated, and they found that it was only home deliveries that were increased. So there's clearly a selective pressure going on. So thank you very much for your time.